I am excited in this episode because although me and Sonia go back a way, we've not really spent any time getting to know each other. So I've got Sonia Richards with me today. Thanks for being here, Sonia.
Thank you for asking me.
Right. So
Uh,
let's kick off with
yeah.
you telling us a little bit about your background. I know you got an MSc in biosciences, but could you tell us a little bit about your background?
Yeah, so I originally, as you say, trained as a biomedical scientist many, many moons ago in Liverpool. And that was in the day before there were any degrees in biomedical sciences. So we had to do the old ONC, HNC form.
Wow.
And once I qualified, I decided I wanted to move to London because that's what we do, isn't it? You know, we
Right.
want to see the world. And so I got a job with the Royal Army Medical College down in London, which I
Right.
loved. So I was working for the MOD, had to sign the Official Secrets Act, all of that, you know. Then moved out to a women's hospital in the Middle East. So I went to Abu Dhabi to a hospital called the Al Corniche, which was women and children. So did that for a little while.
What year would have that have been?
That
What's
was 1987.
Wow, that must have been an amazing experience.
It was an amazing experience, actually. It was a fantastic experience. As you know, I'm also a singer.
Yeah.
So by day, I'd be a biomedical scientist. By night, I was singing in the big hotels and clubs and things in the Middle East, in Abu Dhabi.
Wow.
So I was kind of, running this dual life there, actually.
Yeah.
That was
Well,
quite amazing.
you sang with some and quite a well-known band, didn't you?
A couple of well-known bands, indeed.
Yeah. Go on, say.
Okay. So the very first band was Frankie Goes to Hollywood.
Oh, my word.
And
Yeah.
the second band after that was Dead or Alive.
Right.
Um,
Right. And you still sing?
sporadically, mainly in the bath. But since moving, I've moved back to Merseyside after spending 30 years away.
Yeah.
And all my musician friends really are still down south. So
Right.
effectively the odd thing, but I haven't pursued it since I've been up here.
No.
Don't ask
Got
me
it.
why, but I still love singing. But yeah,
Back at that women's hospital,
yeah,
you're a biomedical scientist.
I
What
was.
what what were you doing for them back there?
So in that hospital, it was, although I was initially employed in histology and cytology,
Right.
screening of smears, obviously histology, the study of tissues,
Yeah.
that was very multidisciplinary. So I was trained in all disciplines, so hematology, clinical chemistry, microbiology, to do on-call work. But I
Wow.
actually decided to leave after just over a year and put out the feelers. I moved to Brighton and luckily got a post at the hospital in Brighton. Again, there was a new initiative coming online for breast screening in
Right.
the UK, which is, this is a new thing. And they wanted somebody that could do both histology and cytology.
Right.
And I was picked for the job. So I
Wow.
became the first breast screening biomedical scientist in the whole of the UK. And that was wonderful because that was
Wow.
amazing, not only obviously with specimens, but with people. Because
Yeah.
a lot of people in labs don't really get to see people, other apart from the doctors sort of within your departments.
Yeah.
So I was part of a multidisciplinary team, which was fantastic. Attending all the multidisciplinary meetings and helping in that decision process, which was absolutely fantastic. The surgeon that sort of took me on and gave me the job, he was brilliant. He took me up to operating theatres, showed me what they were doing with operations, took me into the breast clinic, taught me how to actually palpate for breast lumps. The radiologists were fantastic. They taught me how to screen
Wow.
mammograms. So I had this amazing experience. I did that for 10 years actually. While I was
Like a these days everything's moving towards specialization. It
yeah,
sounds like you were a, having the breadth of a generalist education.
yes, absolutely, and sort of specializing, but still doing part-time, still doing general histology,
Brilliant.
general cytology, so keeping those skills up. And during that time, that's when degrees started coming in for biomedical sciences. So I was very, very lucky. My cytologist back in the day, my head of department sponsored me to do the degree. So and then, even though I was qualified, I went on and did the degree, so the BSc in BMS.
Yeah.
And then latterly, when I changed jobs, I sort of worked all over the Southeast, and again got sponsored to do the MSc. Brilliant. So I'm really, really lucky. We can't take for granted, really, back in the day, and you'll know this, now, so many people have to pay for their education now. Nurses, they stopped the bursaries and all of this. So I was working full time, plus I was being paid to do that education as well.
Fantastic.
Yeah.
Fantastic. I mean, what kind of led you from that? I mean, that sounds to me like a really rewarding job. I mean, my late wife died of breast cancer, so I've had intimate contact with the services. What led you away from that then?
Well, through all of that, I was still singing,
right?
Funnily enough. So I had all my bands and everything down in Brighton, but I got really interested in aromatherapy, of all things.
That doesn't compute with me.
Doesn't compute, does it?
Well, no, from biosciences, which is really kind of like empirical, measurement-based activity. I'm not knocking aromatherapy, but it's in a different domain, isn't it?
Not really, because it's chemistry.
Yeah.
And that's why it sparked my interest. Now, the reason I got interested in all of this is when I was doing my BSc and I had to do, we have to do a project, a dissertation, I decided to do it on breast pain, not breast cancer, but mammalgia.
Right.
I suffered from cyclical mammalgia and I wanted to understand more about it. Right. And at the time at the university, they were running a trial on even primrose oil. Right. So that's really interesting. So in my research, I came across hypnotherapy, I came across acupuncture and aromatherapy as ways of helping with breast pain.
Right.
So that really sparked my interest. I started finding clinical papers about hypnotherapy dealing with pain, proper clinical papers.
Right.
Proper clinical papers for acupuncture. And I thought, okay, this isn't just mumbo jumbo, airy fairy. There's obviously something in this. And somebody was doing a PhD at the time, as I say, on even primrose oil and the efficacy on various lines of breast cells. So I thought, well, this really makes sense. I've always had, I'm one of these people that got very high olfactory senses. So smells are very important to me anyway. They always have been.
Yeah.
I know about smell and memory.
Yeah.
And so I just got interested in aromatherapy. I was interested in the chemistry part of it, and there is a lot of chemistry we go into it.
That fascinates me. But go on, carry on.
Yeah, and there are a lot of clinical papers again about the efficacy of certain, especially places like Germany, Belgium. They're far more ahead of the curve, if you like, with using more natural products in their medicine. Belgium has a whole hospital dedicated to hypnosis for the primary source of anesthesia for people in
what Belgium does.
Yeah, Belgium does. Would you believe it?
Wow. Yeah. You've prompted me thinking about one of my daughters, because I've got 8 children and 13 grandchildren. One of my daughters works in a secure psychiatric hospital. She's on her 3rd baby as we speak,
right.
And she suffers from fibromyalgia.
Okay.
And I was thinking about your work in breast pain. Mm-hmm. Maybe there's some kind of cross, I don't know, connections to be made with fibromyalgia. I don't know.
There may well be, and this is the problem. There's so much kind of research to do. When I became an aromatherapist, I got asked in Brightwell in Sussex, there was a neurological unit attached to the Princess Royal Hospital, and they decided to do a trial with lavender for people with early onset dementia, because they'd found some clinical papers again and research in Germany that said it helps people, because of course what happens is people can get very, erratic, overwhelmed, sometimes, quite angry. They don't understand why a person's got dementia, but of course that then affects the carers as well. So there have been trials on using double placebo, blind control trial of a pretend oil and a real lavender oil, to see whether it could help to just bring aggression down, settle people. with diffusers. So there is a lot of empirical evidence, and this is
Yeah, no, I get that.
yeah.
You're singing. You've learned aromatherapy. What next?
What next? Well, next became hypnotherapy, and that came about because my ex-husband Steve Griffiths, who's still my best friend, he had been a theatre ODA. So he's worked in operating theatres all over the country, and he
Right.
worked in Frimley Park and had attended a lot of childbirth. Done,
Right.
you know, like a scrub nurse in effect,
Yeah.
at that level.
Yeah.
And he had to go in and obviously assist with cesareans, various things. And he got interested in hypnotherapy. And he said, there's got to be something we can do to help women that is non-chemical, so that they can have a much better experience of childbirth, because you're seeing women in distress,
Yeah.
you know. And he said, it's got to, you know, I've learned these techniques in hypnotherapy. Surely to goodness, there's something we can do to teach people, you
Yeah.
know, techniques. And so we kind of looked around and couldn't see anything in the UK back then. So we sort of devised our own little program. And then, at chance, I don't know how he did it, he discovered Marie Mongan in the state.
Right.
So he got on the phone. So,
Rang her up.
yeah, I'm Steve Griffiths, heard about your program, I've been doing this, and I said, well, gee, Steve, you know, lovely to hear from you. Why don't you train in hypnobirthing? There's nobody in the UK doing it.
Wow.
So
and she's the grandmother of all hypnobirthing, isn't she?
Yes, this, you know, she is the source. It all comes from her. So that's what we did. So Steve initially trained in hypnobirthing, and he brought it to the UK. We set up the very first hypnobirthing in Brighton in the UK.
Wow.
21 years ago now.
Wow. I mean, all of the tribes of hypnobirthing now can you know, chart back to Mongan, can't they?
Yeah, absolutely.
Yeah.
And that was great, because then, you know, obviously we got to know Mickey, and we had her over to the UK and various things. And that's what sparked my interest, because I'd gotten into aromatherapy. It was chemistry, it made sense to me. I'm a scientist. Yeah, okay. I'd seen these clinical papers doing my research about hypnotherapy and pain. I thought, well, that's really interesting. So what I'm going to do is I'm going to go for some hypnotherapy to test this out, to see whether it would work for me. And surprisingly, you know, this hypnotherapy lark seemed to be effective.
Yeah.
Then Steve had become a hypnotherapist by then. So I used to sit in on the hypnobirthing classes, and I thought, because I was sort of offering aromatherapy, reflexology, you know, to mums as well. And it clicked, of course, that all of this peripheral stuff, the hands-on stuff, the oils, is fantastic. But that's sort of dealing with effect, and we'll come on to this with IEMT.
Yeah.
Of course, the source is here. The source is what's going on in the noggin.
Yeah.
And if we can work from this position with people, then the rest is fantastic. But we need to go from the mind outwards.
Oh, I get it.
That mind-body connection.
Yeah, I get it.
Just clicks, and I thought, okay, I've got to learn this stuff then, haven't I?
So you studied hypnosis.
Yeah. So
did you do sort of like a clinical hypnosis
course?
I've
done 2 courses. So I've done sort of a couple of year-long courses. Did a clinical hypnosis. A lady called Juno Driscoll, who's lovely, and she's an NLP. She's one of Richard Bandler's master trainers now, and did my NLP with her as well. Because of that training, that was sort of tagged onto the training. Yeah.
So you got exposure to direct hypnotic approach and Milton Erickson language.
Absolutely. Yeah, very much. Steve had trained with Uncommon Knowledge.
Right.
And Uncommon Knowledge, Mark Tyrrell is the son of Ivan Tyrrell, who created Human Givens.
Yeah.
So that approach was very, very obviously Human Givens approach. Very Ericksonian. Steve is a master of Ericksonian language. I'm not. I'm a very left brain person. I'm a scientist after all, you know. So my strengths come from the more direct stuff. So
Right. So at this period of time, you're still singing, I'm guessing.
Yeah, still singing.
And you were working now full time doing hypnosis.
No, I was still working full time as a scientist.
Wow.
And doing all of the other stuff of an evening and of a weekend.
Wow.
So running practices for hypnobirthing, not only Brighton, Winchester, Hammersmith in London. So we were juggling all sorts of things.
Brilliant. When did the transition happen? Or
that wasn't fully. I went part-time around about 2009. I had a hip operation. I had a hip replacement back then. And it just culminated in the journey. I was having to drive all the way from Brighton to Hastings, and it was a long journey, and it was just kind of getting too much. Yeah. So I decided, well, you know what, I've had enough of this. So I left and thought, okay, what do I do? And Steve said, look, we'll sort something out. It doesn't really matter. So I then went to work for a chiropractor, of all things. And then I started doing the massage clinics and stuff for him as well. He actually came and did hypnobirthing with me, him and his wife. Had a fantastic experience. And then a job came up in East Grinstead Hospital. So I went back as a locum, but I only went back part-time as a scientist.
Got it.
I was able to start building up my own practice, independent of Steve. Yeah. And then while I was working part-time, then Steve and I very amicably split up.
Yeah.
And then I actually got remarried about 2 years later.
Wow,
and
cool.
My husband, Mike, is incredibly supportive, and he just said, look, enough's enough. Yeah. Give up the day job. Focus on the stuff that you love. And don't get me wrong, I love the science as well. And I still gravitate very much to that.
It's a fantastic mix, you know, this appreciation of scientific method and being involved with modalities that might be considered on the fringe.
Yeah, but I don't care.
No, it's cool. I love it.
You know, it's like, for me, people that don't embrace all things, they're missing out on so much, because there's so much we can learn. And when I was, you know, for many, many years, I was sat on what was then the MSLC, was it? Yeah, the old MSLCs. I sat on the Brighton one. So of course I was giving the input about language and about the kind of stuff that, you know, wasn't working so well in hospitals and stuff like that. And I did make a little bit of progress with that, but then funding got pulled. We were supposed to be doing a lovely study on the language, because I had, unfortunately, a couple of women that were told in no uncertain terms, unless you have a C-section, you're going to kill your baby. Unless you do this, you're going to kill your baby. All of that sort of stuff. And I, myself and the head of the MSLC, we went to see the head of consultant. This is unacceptable. Yeah. And at one point, I remember him saying, "Oh, well, yes, well, of course, I would have allowed her to go a little bit longer." And we both glared at him. And he goes, "Oh, no, sorry, I didn't mean that. What I meant was..."
Yeah. Well, it seems to me, Sonia, that the intervention that the institution around birth need most is when it comes to language, and it wouldn't cost them much.
No.
You know, I had a woman from Germany as a client fairly recently, and she did not label her birth as traumatic until she went to a debrief. And in the debrief, get ready for this. In the debrief, the reason for the forceps birth was lack of maternal effort.
It's all of that really annoys me.
Me too. And in that moment,
awful.
The whole experience became her fault.
Of course, absolutely. Yeah. And
staggering.
Yeah, and this is the thing. I mean, I was banging on for years about language and change of language. In the end, they said, "Okay, we're going to change delivery suite to birthing." You know, we'll use the word. So they tweaked a few words.
Yeah, well, that's major in some places.
But as you say, it's never been countrywide, has it? And
no.
Each hospital is their own little empire, and rather than having an overall, you know, this is best for the good of all women and their partners and their babies.
Yeah,
I mean, than a sporadic approach which we have.
Yeah, agreed. And you know, before the apocalypse, when I was speaking to, you know, hundreds of student midwives, I used to get so discouraged at hearing students using language
Yeah,
that they picked up from mentors.
of course, of
You know, it's
course.
very, very sad. And
Yeah,
we were talking before we, started recording about levels of women in this country that regard their birth as traumatic. Something like 200,000 a year, or a third of the birthing population classify their birth as traumatic. Now, the NICE guidelines currently is recommending things like CBT and EMDR, and there's some encouragement in the evidence that can be effective, but you train in something that sounds similar but isn't. Could you tell us a little bit about IEMT?
IEMT. Well,
Yeah,
I
IEMT.
actually train in EMDR because that was tagged onto my hypnotherapy training.
Oh, you did EMDR.
Yeah, and what was really interesting, because it never worked for me.
Right.
And and I'll give anything a go. But for me personally, it didn't seem to work, and I didn't understand why.
Right.
And again, I just happened chance was attending an NLP meeting one evening with Steve. And
Steve
he was my husband, my ex-husband.
All right.
And the talk was, I've never heard of this guy, by Andrew Austin. Oh, okay, well, some eye movement thing. Okay, well, we'll turn up and see what this is all about. And the test exercise, which I still do, and I train and I do with all my new clients, which is a very, very brief exercise using eye movements about a memory that's vivid, that has a kind of negative feeling around it. And I had something going back to school time from years and years and years ago.
Yeah.
And literally within about 30 seconds, that memory changed and that feeling had changed.
Wow. So this was using the methodology that Andy Austin
This
has kind of developed.
Method, and which was still in its infancy back then, because we're talking about 2007. So
yeah,
still hadn't really developed to the way we've developed it now. Right. And then Steve went along to one of Andy's very first trainings. Now, here's the thing. I wasn't trained in NLP back then. I was in hypnotherapy. So I thought you had to be an NLP
right.
to do IEMT.
And
so
you don't, do you?
Training.
No, you don't, do you? You can do the training as a standalone.
Absolutely. Yeah. But back then, because I was at an NLP meeting, I thought, obviously got to be an NLP person before I can do this IEMT still. So it wasn't until a couple of years later then I went on and trained in IEMT.
Now you're particularly, well, you're interesting generally, but you're interesting in this regard because you've done some EMDR training. Is that right?
Yeah, and it was only, a weekend, so it wasn't like the full 6 months, etc. But yes, that was tagged on.
Yeah, and EMDR can trace its heritage to the model of NLP as well.
Of course it can, absolutely. It was proffered that Francine Shapiro actually borrowed it from John Grinder, and there's all of this sort of stuff going on. I don't get involved in all that.
No, nor me. Some people in the NLP community are the worst advert for a model that claims to create communication at a deep level.
Absolutely.
So I would say most people listening to us chat now have no idea what IEMT is. Can you? I know you've written a book on it, and I'll be sharing the link to your book. And Andy Austin gives a rave review of the book, so it's got to be good. But could you give for those that have no idea, could you introduce them to the model?
So the full title is Integral Eye Movement, either Therapy or Technique. So I chose to put techniques on the book, having discussed that with Andy, because I don't really see it as a therapy per se.
Right.
I know people will want to say it's a therapy, but when this model first came about, as Andy will quite often say, it was only a 4-hour workshop. It's a set of techniques that, he's expanded.
Yeah.
But because anybody can train in theory, I always put the in theory, without any therapeutic background, I don't like to call it a therapy per se.
Snap.
Okay.
I feel exactly the same way about the process I teach, but yeah, go on, say.
So I prefer to call it techniques. So
Yeah.
what it encompasses is, yes, there are eye movements as part of the process. And we know that when we are searching for memories, when we're searching for feelings, experiences, our eyes move around.
Yeah.
And if we have had a traumatic experience, which doesn't have to be, you know, a huge thing, but if it feels traumatic enough to somebody, there will be a process in place. Somebody has learned to feel a certain way about certain things.
Yeah.
Now, IEMT is kind of predicated on two questions. How did this person learn to feel this way?
Right.
They learn to be this way. So we work not only at a kinesthetic level of feeling, but we also, and I think more importantly, work on the level of identity.
Right.
Who that person is, who they've learned to be, who they are being, because the who they are, as I always say, the who we are actually will definitely feed into the how we are.
Yeah.
Who we're being then.
That's interesting. So it's almost at the outset a modeling process. You're modeling how the client is achieving this set of feelings and behaviors.
Absolutely. And that is done not only you know, through the kinesthetics that they're feeling and their identity, but we're looking at for the patterns that they're running as well. So these 5 primary patterns of chronicity, as they are called, and people go, chronicity, what's that mean? Well, if you think
Just
of
chronic,
it just means long term. It's been there for a long time. That's all it means.
Yeah.
So these are patterns that most likely developed as young children and have been ingrained because they're so unconscious.
Yeah.
Most people would never know that they're running.
The pattern has just become who they are.
Exactly.
Yeah.
So in the book, I call it the Foundations of Imt, because really, unless we are addressing those fundamental patterns that is keeping issues in place for people, it's not the start of the issue, but it'll keep the issue in place that they're running certain patterns. Let's address that in the work that we do.
Yeah.
All we're doing is a bit of nice eye movement stuff, make them feel a bit better. Off you go.
Because these patterns of chronicity, as they're called, we can assume because of, you know, the evolutionary model, we tend to, if something works, we repeat it everywhere. We can assume that they're applying these patterns in pretty much every domain of their life.
Absolutely, yeah, absolutely. And I recently sat in, I did a couple of lectures with Richard Bandler, and he said, you know, for human beings, the thing that we are searching for more than anything, our behavior, sort of again predicates around familiarity.
Yeah.
And so if something becomes familiar, then it feels right, or it feels okay. So we're going to stick to what's familiar. Now, that word familiar in the IEMT model is very, very important. And I use that word familiar. Is that familiar? Is that familiar? In different parts of the model.
Right.
Because I also want to talk language that people understand. I don't want to talk highfalutin stuff that is made by a psychiatrist or a psychologist that people really don't understand.
Yeah.
That's familiar. That model that I've just written up for you, is any of that familiar to you?
Yeah.
Because then they can log into that, then they can do a little transderivational search and find what is familiar.
Yeah.
As I say, that word is very, very important.
No, I get it. It's kind of directing their meaning-making search.
Absolutely, yeah, to their own experience.
Yeah.
Because it can only ever be their experience, can't it?
Yeah.
At the end of the day.
So we've got the eye movements in the context of, we acknowledge that people seem to be moving their eyes when they're accessing various parts of their experience. And then you've got these 5 patterns of chronicity. Now, I'm assuming that in a session, part of your work is identifying which one of those patterns.
Absolutely.
Ever a combination of them?
Oh yeah, always.
Always.
Pretty much. The patterns, most people will run some of them some of the time. A lot of people will be running, or some people will be running a lot of them or all of them all of the time, depending on, okay, their mental health, for example.
Right.
So people that do have mental health issues might be running more often than others. But because they become, as I say, part of who we are and how we operate in the world. Now, they actually came about because Andy was doing some work on long-term anxiety. And he wanted to know, why is it these patients, clients can't be helped? What is it that is, again, seems to be consistent over this population of people that is being missed? And that's when he started identifying these patterns through linguistics, obviously.
Yeah. So he picked up markers in their conversation, their posture, their body movement.
Absolutely.
That were consistent. Across multiple clients.
Exactly. So then, once, and somebody said to me recently, he trained me very recently, and was like, you know, he's a counsellor and he's a therapist of all sorts, psychotherapist, and he said, how did I not see these? He said, I've been doing this job for 20 odd years. How did I never see these patterns? He said, and now I know, I see them everywhere and I hear them everywhere. And once I always say, it's like tuning your IMT antenna, or you put your IMT goggles on and your IMT hearing aid, and once they're applied, you know, we're seeing it and hearing it everywhere.
The way learning works, I think we have to make a distinction first before stuff comes into the foreground.
Exactly. And for people that are running as patterns of chronicity, yes, there are often multiple patterns of chronicity. As far as anxiety is concerned, one of the big giveaways is somebody that what ifs. So the what if. Now, I know in CBT they talk about the what if, but they don't actually follow through as to why there's a what if. So we are very much looking at cause rather than just effect. So a lot of people will work with anxiety and we'll do this thing to the anxiety and that person will feel better, and that's great. But what caused the anxiety in the first place? And that often gets overlooked. So to me, it's not just about working on the effect of things. It's about, okay, so how did this person learn to feel this way in the first place? And was there a learning event somewhere along the past? We might not ever get to the very first time ever somebody did this, but if we can get a close enough match to an experience and then the results
work with that,
and work with that, then we've got a really good chance of then disassociating them from that response that has become ingrained through the amygdala, through the hippocampus. It like formulates this sort of package of response. So what I always say with IMT, especially for the sort of memory work that we do, the kinesthetic work, if you like, is that people have these memories that are like a fully formed jigsaw puzzle. And what we're doing is breaking the jigsaw puzzle up.
Nice.
And then those bits of that memory engram can then be stored and properly consolidated, properly processed, properly consolidated, and stored to where it needs to be. And it then makes it much more difficult to drag all of those pieces together, because a memory is thousands and thousands of bits of information. It's not just, a fully formed thing.
I like that jigsaw analogy. That's really cool. And of course, if you're working with one prototype or one category prototype of an experience, potentially work with one and it's a domino effect.
It certainly can be, and one of the reasons that we work the way we do, which is much more specifically with the eye movement. So yes, we do have basic patterns that we can do, which is sort of the horizontal patterns and diagonal patterns and fairly fixed angles. But we also are looking for the integral eye movement. So that little bit, that little wobble, that little flick of the eyes, which means there's some change in the representation. Some of the memory may have come in, or somebody will move their eyes, in a big jump, often away from the experience because it's uncomfortable and they don't want to experience that experience. In order to break it up, we need to kind of
Got it.
force the movement back.
I got it. So becoming skilled and effective with the model, calibration is a big
Yes,
chunk.
very much so. Yeah, it is. Yeah.
So you're not working in the dark. You're seeing stuff and testing stuff.
Absolutely. Yeah, definitely is. And of course, again, one of the things that I really talk a lot about is body language.
Yeah.
Of course, because we cannot underestimate the body language of people and those little micro expressions,
Yeah.
especially when it comes to things like patterns of chronicity. Because if somebody starts to run what is called the 3-stage abreaction, often the first signal of that will just be a little flick of the eyes or a little tightening of the lips or a little touch of the shoulders.
Yeah.
That's given me a signal.
Got it.
That all is not right with that person.
Yeah.
Something I've said or have done has pressed a button. Now, I don't mind pressing buttons for people because I don't mind being provocative at times, because I know that change can't always be comfortable.
Yeah.
And sometimes we have to go through a bit of discomfort in order to get to the other side.
Yeah.
So, you know, I'm not going to blatantly cause people discomfort, but getting to a little, okay, I'm not now in my comfort zone. Because if I stay in my comfort zone, I'm unlikely to really do the change.
Yeah.
If I start feeling okay, I'm at my comfort zone now, there's a learning that can happen.
Yeah. The 3-stage abreaction is when a client builds up to some kind of reaction that they blame you for creating.
Yes. So basically what they're saying is you have to change to make me feel better. I don't want to change. It's all your fault. It's nothing to do with me.
Yeah.
You know, but some people run this behavior, and I'm sure you will know people in your life do this sort of behavior, that it's always everybody's fault and everyone has to come running around to pacify and calm and bring them gifts or whatever it is that we need to do. And sometimes those stage 3, which can, yes, be a big explosion and throwing plates and whatever, but it isn't always that. It could be a burst of tears. It could be, oh, I've got a migraine now and it's all your fault and I'm going to bed and I'm walking out.
It's almost as if they've trained those around them.
That's exactly what they do. No, they have trained us to walk on eggshells around them so that we're, you know, keeping everything fine for them.
Yeah.
Rather than them owning up to their own behaviours.
Got it. Now, we've been talking, this is a great conversation. I'm really enjoying it. I've got 2 kind of like final questions and then sort of like another question at the end. So let's imagine someone has trained in the model.
Yeah.
And they're seeing a client. How do client sessions run?
That's going to be totally different depending on the person and the session. Personally, I like longer sessions. So I will do about 2 hours with a client, because I want to be able to explore things like the patterns of chronicity, not just do a little bit of amelioration of a feeling and do a little bit of eye movement to make them feel better. Yeah, that's important, especially when someone's coming because they're feeling quite wretched. But I want to discover, how did the person learn to feel this way? How did the person learn to be this way? So my session would run, it'd always start with a new client with that test exercise of something that's troublesome or bothersome. It doesn't have to be huge. And I'll always give them a story. So when I was 8 years old, I got locked in the toilets in a big department store in Edinburgh, or some other story from childhood. Oh, and it made me feel, and when I think about it now, God, it's still really vivid, and I've still got that feeling. We've got something like that. So I'm not going straight into the problem straight away, because it's such a brilliant convincer that they can formulate change. I'm not saying I'm doing it to them. I'm saying, how brilliant is your brain? That
it's a quick. It's a quick win early on.
It really is. So I'll always start off with that. I will, I always ensure that clients have done a full client assessment. So I've got a whole set of questions, plus a medical questionnaire, because there are contraindications to this. So we want to make sure that somebody's not coming that's just had a smack over the head or have the eye poked out or whatever it is. So we need to double check that, okay, medically everything's fine. If somebody is actively in addiction, no, that's not going to happen. So they need to be clean before they come. So, you know, so we've got to be really sensible.
Very clear parameters. That's
very much so. And that, you know, there kind of wasn't any of this. And then we formulated the association. So I helped to bring these sort of criteria in, and also things like the case study protocol, because there was none of that either before.
Yeah.
So practitioners have to go through a process now before they are given a certificate. And I'd rather call people a practitioner than a therapist, if we're going to call them anything.
Me too.
So that's, you know, I'd start off the kinesthetic stuff. I'd go through the questionnaire with the questionnaire, and it's brilliant. And also I may have had a telephone conversation with them. I may even had a free 30-minute session with them, you know, just to check that I'm the right person for them.
Yeah.
I will tell them I could be quite provocative at times. Is that okay? I'm very straight talking. I will be picking up on those patterns of chronicity. I will be picking up on identity statements as well. Very important.
So you're modeling.
You know, so it's like, you know, the identity comes from the work of David Groves with the four pronouns. There's lots of other stuff to it as well. But I'm going to pick up those identity statements where there seems to be an incongruity or a discomfort between aspects of their identity. Well, you know, I'm just beside myself with worry. So I am just beside myself with worry. So there's some location difference. Often there is some age discrepancy as well with aspects of identity. So I'm picking all of that up in the questionnaire, in the conversation. So then I'm sort of formulating how I'm going to work with that person.
Got it.
So we've got something called the 3 pillars. It used to be the 3 pillars of depression, but again, that's a kind of anxiety model which shows that a lot of people can cycle around sets of emotions in their life. It's very rare, unless we're bipolar, that we're going to go from rage to love. There's usually steps in between. So there are these emotions that people chain and cycle around. So we can demonstrate that. And if they're using words like guilt or anxiety or anger or regret or shame, I'm thinking, okay, that'll fit in with that model. So I can demonstrate to them via a story how this works.
Brilliant.
How familiar is that? Oh my God, that's my life. You know, how many times oh my God, that's my life. So then I can choose the emotions that are the right emotions or feelings specifically to work with that person.
So that you can break up
the
jigsaw puzzle.
Exactly. So we can then start working on the component parts and be working on the patterns of chronicity. And every time they say maybe, probably, 6 or 7, I've made a note of that. Now, here's the thing. I have this little thing that a lot of my students now have, which is a little bell. And every time a maybe man pattern happens, and they've done it a couple of times, I'll say, okay, next time you say maybe, probably, you're going to hear this bell.
So you're pattern interrupting.
And it becomes a great joke with people. It's like, oh no, don't press the bell. I know I said 6 or 7. It's 6, definitely 6, because we want people to be specific with their experience. Part of the problem they're here is because they're unsure of their experience.
And it's a lovely pattern interruption.
It's very, very simple, and it's good fun as well. It's good fun.
Fantastic.
I like to have a laugh in sessions as well.
So let me ask you then. So there are a number of practitioners out there or therapists out there. What would they charge on average for a session?
It depends on, again, in the country where we are. Down in London, it would be about £150, roughly, or more. People in Harley Street would be charging 200, 300 quid a session, you know. Up north, up in Scotland, it'd be more likely 50, 60 quid, because it depends on the demographic. Of
course it does.
And the area we're at.
I train people in Dubai that are charging £1,000 a session, so it's context, right?
It is context related, and you know, and I would never say, well, there has to be a fee that we all charge. A bit like Old Pain to Go is a bit like that. You know, everyone has to kind of charge the same fee, and I don't think that's right. I do pro bono work and stuff for people as well. So, and if the children, I'll reduce the fee, and so you know, I want to be flexible.
Set fee doesn't work, in my opinion, because you can charge what you like. If the market won't sustain it, you're still going to earn nothing.
Exactly. So I would say on average we'd be talking around about £80.
Yeah.
Bear in mind, depends on the length of the session as well.
Yeah,
So
of course.
I offer 2 hours.
Yeah.
For a
So
session.
now the last question before I ask you a frivolous question.
Frivolous question.
Uh, there will be birth workers out there, birth
Mm.
professionals that want to train
Mm.
in this model.
And have trained, thankfully.
And have trained, yeah.
Yeah.
Oh God, you've trained quite a few people.
Yeah.
How long do the trainings last, and what's the pathway to accreditation or a certificate?
Okay, the way I work this
Yeah.
is the original training was 2 days. Now because I'm training this way through the screen, 2 days is a long time for people to be glued to. So I break it up into 4 sessions over 2 weekends.
Oh, nice.
But having done that, I've kind of extended my my inputs, and because I'm always looking for new stuff, new evidence, I like to feed that into my courses. So I do add on a hell of a lot more,
of course,
than perhaps other trainings do. So it's split up over 4 sessions. Now, if somebody is totally a non-therapist, they've come to this because they've experienced IEMT and they want to train.
Yeah.
Of course, they can still train. However, because of the inputs that I have to put in, the way I was a university lecturer, and I still train with these strict parameters.
Yeah,
so
good.
I'm not just going to say, okay, do one case study, 10-minute video and send it to me and you pass. Yeah. Somebody that's a non-therapist will do a minimum of 3 or more case studies.
I got that.
And they have to do some self-use, self-reflection.
Yeah.
They do a PTSD story. We haven't even talked really about the trauma model, which is amazing.
No,
but
we'll have another section.
We'll fit, and they need to do a story that would fit in with that. I give them an exercise on identity statements and patterns of chronicity that they need to pick out as if it was, a questionnaire in front of them, and I want to see
Very good
out of that. When I do the assessment on their videos, we do it as a one-to-one. They send me the video. I will always have a quick look at it, make some notes. Then we sit together and we go through it. And so I'm getting them to feed. So I'll say, so what did you miss there? Or what have you done there?
Yeah.
So they're getting a live, sort of feedback through that.
It means that their certificate in the end will not just be a receipt.
No, absolutely. I would never, ever work in that way. I also, with my trainings, they get at least 2 and sometimes more, depends on how long they're doing their case studies over, post-course practice sessions with me.
Yeah.
So I come back again, we do a couple of hours, post-course stuff. And if it goes on a bit longer, and I've got another course coming up, they can attend those as well.
Yeah, got it.
I run my free IEMT tea parties.
Yeah.
So again, they run not just about IEMT. I bring in people up from all of the fields that are sort of something to do with change work, so that they can talk to other professionals and have this interaction, learn new things. So I run them every couple of months. So next month there's going to be sand play with Matcha Bennett, so just something different. It's nice. It's just before Christmas. I thought that'd be really nice. I also, work with metaphors of movement, which is Andy's other modality. Yeah. So in a session, you're saying, how do I work? I'm always listening for those metaphors as well.
Yeah.
Because I may need to start there before I even do any.
Yeah. It's like being in a deep pit.
Yeah.
Yeah. So tell us, where can people find out more about your training dates? Find out more about you.
Okay. I've got my main training website, which is integralimmovement.com. So very, very welcome to have a look on there. And there's blogs and there's lots of stuff on there to have a look at. And then there's my Facebook. So they can just look me up on Facebook, Sonia Richards. That's nice and easy.
And they can Google you as well.
They can Google me. They can look at my alias as a singer called Sonia Naz. So there's a few videos of that up,
Wow. Have you got any trainings coming up?
Yeah, I have. So the next level 1 is going to be in January. So that's 22nd, 23rd. and
All right.
29th, 30th of January. So that's level 1. I also teach level 2.
Yeah, got it.
Take it on. So that one's in February, March. But I'm doing an intro to metaphors of movement, and that's on the 5th of December. So that, I say, it's like having a lovely dive down the rabbit hole and really experiencing something totally different.
Right.
Yes,
Well,
it works so well with the IEMT.
brilliant. And to finish off, what are you listening to at the moment? What sort of music do you listen to? Have you got a favourite at the minute?
I don't have a particular favourite. I do love Jessie Ware actually at the moment. So she's one of my favourite female singers. I'm very much I like change.
Yeah.
So, although I've got my staples like David Bowie, of course, hero. But I'm always listening out for. I listen to the radio more than I do listen to CDs of stuff, because I like new stuff.
Did you ever meet David Bowie?
You know what? I missed him by half an hour. We did a gig with Dead or Alive, and we did a gig down in the London Hippodrome, and we left and he came half an hour. And I was gutted. So, but I've met many people.
And one last question then. What are you reading at the minute? Anything?
I've got about half a dozen books on the go, because I always do.
Yeah, me too.
I've just revisited James Herriot. There was
nice.
a series on the TV, so I've bought the whole collection, so sort of ploughing my way through that. But sort of therapeutic wise, I've got The Self-Illusion, actually, it's right in front of me, by Bruce Hood.
Worth a read?
It's brilliant work. I really, really like it. It's about identity, which is my subject. I love identity work. And still ploughing my way through Lisa Feldman Barrett's How Emotions Are Made. Which again, that just sort of took Ekman's work and almost threw it in the bin.
Yeah, it did.
Again.
I've read that book.
Yeah.
And I'll tell you another one, just while you're talking about self-identity, Transformation of Yourself. I
haven't got that one.
By Stephen Andreas.
Oh, right. Okay. Yeah. Yeah.
And it's his modelling of self-identity.
Yeah.
Well worth a read. Hey, Sonia.
And of course, I'm reading my own book. I'm going to flick that up. Integral eye movement techniques.
Yeah, well done you. And Sonia, thank you very much for being so generous with your time.
It's been brilliant. Thanks so much. And I'm sure we'll chat again.
We will.
And next time.
Yeah, and thanks for listening. We're done now. Bye.